Good evening, friends. Welcome to this evening Tuesday critical care meetings. It has been 2 years of journey since we began this critical care CMEs webinars online. And it has been a pleasure for us to actually interact with many senior clinicians, many students, many experts in the field of critical care during this journey. Over the last few years, I realized that the ICU related psychosis, ICU related delirium, ICU related agitation, it can be way vary between a simple irritability to a aggressive behavior, from a drowsy state to a coma stage. So ICU related neuropsychiatric phenomena are not uncommon. We all come across, and data suggests if any patient develops a ICU related neuropsychiatric behavioral changes, those outcomes may have a different than what generally happens in a patient who don't have any neuropsychiatric symptoms or behaviors. So it happened to us that we have our senior consultant in the Department of Psychiatry, Dr. Naveen Kumar, who joined Yashoda Hospital, Hitec City. And being visiting frequently to us, and when was interacting, we come across a lot of new concepts, new ways of thinking in this psychiatric illnesses in the ICU. Whether you say substance abuse, whether you say ICU related delirium, where you say a organic cause of a neuropsychiatric behavior, or a malingering or a hypochondriasis. There's a wide spectrum of things which go across. Believe me, sometimes we struggle with these patients more than other patients of normal physiological disorders. So today we thought we will bring a topic which is of probably more interest to many of us, and a new area in the Department of Critical Care Medicine on ICU, that is psychiatric emergencies in intensive care unit. And to bring us an overview to that, we have a dynamic senior consultant in the Department of Critical Care Medicine of Hitec City Hospital, Dr. Siddarath B, who actually post-graduated and then went on to do fellowship in critical care medicine from Yashoda Hospitals, and now working as a senior consultant. So over to you, Dr. Siddarath. The flow will be something like this. After the overview from Siddarath, we will take questions to Dr. Naveen, who will give their expert opinion in different areas. Over to you, Dr. Siddarath.
Good evening, sir. For the next half an hour or 40 minutes, we will be discussing regarding the psychiatric emergencies that we face in the ICU. Nowadays, the psychiatric emergencies have been increasing in the ICUs. And regarding, if you see the psychiatric disorders in the ICU, it ranges somewhere between 20% to 60% according to the type of the ICU that we are working. And when we have done the breakup of the psychiatric referrals that we give from the ICUs, approximately 15% of the referrals were regarding the alcohol-induced and related disorders, and around 20% were regarding the acute and chronic organic brain syndromes. And regarding 30% of the referrals were regarding the suicidal attempts, and around 12% regarding the anxiety disorders, and rest from depressive disorders, psychotic disorders, and other psychiatric illnesses. And dating back to 1965, there was first evidence of the psychiatric consultation in the intensive care unit. Even in those days, there was a psychiatric consultations and special referrals for the psychiatric referrals for the ICU patients. And regarding the topics that we are going to discuss over the next 30 minutes will be the 5 emergencies in a broadly classified form. The first one will be the delirium and agitation. Delirium is the most common cause of agitation in the hospital, particularly in the ICUs, which is neuropsychiatric manifestation of the systemic disturbance. Around 20 to 50% of the lower severity ICU patients and around 60 to 80% of patients on mechanical ventilation are supposed to be having delirium. It is a clinical diagnosis and there is no diagnostic blood test, electrophysiological test or any imaging test to diagnose delirium. And the definition of delirium goes as: delirium is a syndrome with acute disturbance of consciousness from baseline mental status with inattention accompanied by a change in cognition or perceptual disturbance that develops over a short period of time and fluctuates over time. This is considered to be the sixth vital sign in ICU after heart rate, BP, saturation, respiratory rate, temperature. Then the sixth one goes for the delirium. In the pentad of delirium being disturbance of consciousness, change in cognition, development over a short period, fluctuation, and perceptual by the medical condition or its precipitation by a medical condition or its treatment. This is very important because it is the most common complication in the ICU stay and it is going to increase the aspiration risk, it increases the length of stay in the hospital and ICUs, it increases the days on ventilator, and it is going to increase the long-term cognitive impairment of the patients. And this is a mnemonic for remembering the etiology of the delirium. That is the etiology being the infections, withdrawals of alcohol, sedatives and other things, and acute metabolic derangements and electrolyte derangements, and trauma, CNS pathology, hypoxia, deficiencies of vitamins, endocrinopathies, and acute vascular hypertensive crisis, arrhythmias, toxins, and heavy metals. And the pathophysiology of delirium being the GABAergic and cholinergic neurotransmitter systems play a contributory role. There is an increased risk associated with the use of GABA agonists and anticholinergic drugs. Central cholinergic deficiencies may be final common pathway. Other hypotheses include excess dopaminergic activity and direct neurotoxic effects of inflammatory cytokines. And studies using MRI have shown a positive association between the duration of delirium in the ICU and both cerebral atrophy and cerebral white matter disruption. And the subtypes of delirium going as hyperactive, hypoactive, and mixed, and the most common being the mixed and hypoactive, and the very least common type being the hyperactive type of delirium. Older age is a strong predictor of hyperactive delirium. The average onset of delirium being on day 2 and the average period of delirium in ICU stay being around 4 days. The most important step in the management of delirium being its early recognition. The steps of assessment of delirium, the first step being the assessing the level of consciousness by using Richmond Agitation Sedation Scale or RAS. The second step being the assess the content of consciousness by using the CAM ICU score. This is Richmond Agitation Sedation Score, where -3 and above, where we can assess for the go for next step and assess for the CAM ICU score. And if it is -4 and -5, which indicates deep sedation and unarousable state, and we have to stop the examination there, and we can't go for the next step of ICU CAM ICU score. Two scales that are in common use being the CAM ICU score and intensive care delirium screening checklist. CAM ICU score reports a dichotomous assessment at a single time point, whereas ICDSC lists signs that can be observed over a period of time. This is CAM ICU flowchart. The first point being the acute change or fluctuation course of the mental status. We have to see if there is any acute change of the mental status from the baseline, or has the patient's mental status fluctuated during the past 24 hours. If there is no such fluctuation, then CAM ICU is negative and there is no delirium. If at all there is any fluctuation in the mental status, we have to check for the next step, that is inattention, where we have to interact with the patient and ask the patient to squeeze the hand whenever we read out certain words, and ask to press when the patient, when we spell out that particular letter, like say SAVEAHARD, and we spell out those letters, and once we have to ask to squeeze our hand whenever letter A is pronounced. If he is unable to complete the letters, we can go for picture assessment. If there are 0 or 2 errors, then CAM ICU is negative and there is no delirium. If there are more than 2 errors, then we have to check for the next level, that is alternate level of consciousness. If RAS is 0, then CAM ICU is positive and delirium is present. And if at all RAS is more than other than 0, CAM ICU score is present and delirium is present. And if RAS is 0, then we have to think for the disorganized thinking, and to know the disorganized thinking, we have to ask few questions. Whether, like, will a stone float on water? Are there fish in the sea? Or some like similar questions. And if there are more than one error, then delirium is present. If there is 0 or 1 error, then CAM ICU is negative and there is no delirium. So next comes the delirium protocol, where we assess for CAM ICU and RAS scoring system, and if patient is non-delirious and CAM ICU is negative, then we have to assess the brain function every shift and treat for the pain and anxiety. If at all patient is very drowsy and analgesia, we have to check the analgesic levels and the sedation that we are giving, and we have to do the spontaneous awakening trial, and we have to assess the target sedation goal every shift. And if the patient is delirious and CAM ICU is positive, then we have to check the RAS score. If at all RAS is 0 or +1, we have to check for adequate pain control and give typical or atypical antipsychotics. And if at all RAS is -1 to -3, that is if patient is drowsy, then we have to again assess for the sedation and perform a spontaneous awakening trial. And if RAS is +2 to +4, and if the patient is having pain, we have to give analgesics. And if the patient is still agitated in spite of giving adequate analgesics, we have to go for typical or atypical antipsychotics. The managing for ICU delirium goes like this. We have to look for it. We have to communicate between the nursing and physicians. We have to identify and treat the correctable risk factors. We have to optimize non-pharmacological interventions and pharmacological interventions. So goal-oriented sedation with daily wake-up should be performed. The pharmacological management goes with the first drug being the haloperidol. It is a typical antipsychotic, and it is recommended by Critical Care Medicine Society for delirium. A recommended starting dose would be 2 to 5 mg every 6 to 12 hourly, with a maximum effect dose around 20 mg per day. And we have to be careful regarding the extrapyramidal syndromes, seizures, neuroleptic malignant syndromes, and tattoo dyskinesias and prolonged QT interval, because they are known side effects and complications with the haloperidol. And the atypical antipsychotics on regular use may be quetiapine, risperidone, olanzapine. And there is also some studies which were showing dexmedetomidine being significantly lower incidence of delirium when ICU patients were sedated with dexmedetomidine compared with midazolam, lorazepam, propofol, and morphine, and even haloperidol. The non-pharmacological management being orientation with the patient should be given the visual and hearing aids. We have to communicate with the patient, and we have to reorient it with the patient on regular basis, and we have to keep familiar objects and familiar people along with the patient, and consistent nursing staff should be maintained. Patient can be offered news, music during the daytime, and the environment in which the patient should be is staying. The sleep hygiene should be there, that is, light should be off at night and on during day, and sleep aids should be given, and control excessive noise at night, and ambulate or mobilize early and often. The second emergency or issue, psychiatric issues that we are going to see in ICU is regarding the anxiety, depression, and psychosis. Anxiety disorders in ICU are secondary to the ICU setting itself, the patient's medical illness, and the medications. It can be caused by multiple things like medications, difficulty in weaning from ventilator, sedate use, alcohol or nicotine and antidepressant withdrawal, the fear of the death or the fear of disability that the patient is undergoing, the misconceptions about the illness, and the misinterpretation of the display and alarms from the monitors, and the restriction of usual activities. And all these things can create a lot of anxiety, and in severe cases can create panic, and this can indirectly cause a lot of tachycardia, palpitations, hypertension.
Just sorry for that interruption. You can go a little slow. I think we need to follow you.
Okay, sir.
You're going very fast. You can go 2 slides back. I think from next slide onwards. Yeah, you can go slow. It's too fast now.
Okay. So we will discuss again disorders in ICU. Anxiety disorders in ICU may be because of the ICU setting itself and because of the patient's medical illnesses, because patient may be having multiple illnesses and he is going through multiple admissions and multiple consultations from various departments, and multiple medications, a long list of medications will be given for the patient in ICU, and all these things can create a lot of anxiety to the patient. And because of the medical conditions, patient might be having hypoglycemia, hypoxia, and evolving myocardial infarction. All these things can generate an anxiety in the patients. And medicines like isoproterenol, which are being given for cardiac rhythm disturbance, and theophylline that are being given for pulmonary diseases and bronchospasm and all, can also create a lot of anxiety in the patient. So some patients may be having difficulty in weaning from the ventilator, and some patients will be suffering from the alcohol, nicotine, and other antidepressant withdrawal. All these things can create a lot of anxiety and panic state in the patient. And due to the various diseases that the patient is suffering, he may have the fear of death or fear of disability. He may have many misconceptions about the illnesses that the patient is going through, and there may be misinterpretation of displays and alarms from the monitors. And because of the restriction of usual activities, he had to do day-to-day activities in the bed, and he can't use the washroom, and all these things can cause anxiety in the patients. Because of illnesses and hospitalization, patient ability to handle the real life problems may be impaired. Because of the ongoing his real life problems, he may have the enhanced anxiety, which may lead to panic disorders. And the problem is the panic disorder and other anxiety disorders, the symptoms overlap with the regular cardiorespiratory disease. Even because of the anxiety and panic states, the patient will have tachycardia, tachypnea, hypertension, sweating, palpitations, and these may be this may match up with the cardiac and respiratory disease problems symptoms also. And this post-traumatic stress disorder, this is a common during or after an ICU admission. Factors that contribute to the post-traumatic stress disorder are the prior psychopathology, increased benzodiazepine administration, and post-ICU memories of frightening or psychotic experiences during previous admissions or the present admission. Management of anxiety disorders, either by pharmacotherapy or non-pharmacological therapies. The pharmacotherapy, the most important is the benzodiazepines, that is lorazepam is the most preferred one, and there should be effective pain management that helps the patient in decreasing the anxiety also. The non-pharmacological therapies being providing accurate medical information to the patient, having a supportive accompanying family member with the patient, and explaining the roles and meaning of the monitoring equipment. Whenever there is a red light buzzing on the monitor, patient may be very anxious seeing that, and whenever one doctor or a paramedical person or nurses and all comes and explains that is not a problem, that is just a movement artifact or something, he may feel much decrease in anxiety. And also emotional support and reassurance regarding the treatments and his disease conditions will help in relieving the anxiety. And psychotherapies like psychoeducation, crisis intervention, supportive psychotherapy, and hypnosis, all these things helps in relieving the anxiety. Yeah, the next thing is the depression in the intensive care unit. 17% of the patients admitted to ICU have the history of taking SSRIs or serotonin norepinephrine reuptake inhibitor SNRIs. 28% of ICU survivors report depressive symptoms. Symptoms of depression in ICU may result from acute illnesses or emotional reaction of the patient to acute illnesses secondary to medications, or it may be because of the patient may have an independent major depressive disorder. The treatment of the depression in ICU in most patients is we have to assure that the illness is time limited. Patients require prolonging stays, respond to the initial efforts for rehabilitation or psychotherapy. We have to stop the offending drugs, and SSRIs are the drug of choice in ICU. We have to be very careful when prescribing ferritin sodium, digoxin, and warfarin because of the low therapeutic index. Drug level monitoring should be done when SSRIs are restarted because there are drug-to-drug interactions and the drugs of the phenytoin, digoxin, and warfarin may vary. Sertraline, escitalopram, and citalopram are minimal risks of drug-to-drug interactions and they are better tolerated in the ICUs. You have to be careful when prescribing venlafaxine and desvenlafaxine because they can cause elevation of blood pressure even at therapeutic dose. When bupropion is advised, it can lower the seizure threshold and it can trigger seizures in the patients. The next thing is the psychosis in the intensive care unit. The psychosis, one type of psychosis that we have already discussed, that is the delirium with psychotic features, and the other types being the psychosis associated with the dementia and other disorders like head injury, Parkinson's disease, HIV, and Huntington's disease. All can generate psychotic features in a patient in ICU. Psychosis associated with dementia. Examples may be precipitated by SLE, hypothyroid, hypercalcemia, hypoglycemia, vitamin deficiencies, and untreated infections. So, and also there is a black book warning regarding giving of and prescribing antipsychotics because it has been found to have 1.6 to 1.7 fold increased risk of mortality. So, risperidone and olanzapine can be used when there is persistent severe aggression or psychosis in case of Alzheimer's disease. Whereas in psychosis in Parkinson's disease, non-motor symptoms such as hallucinations and delusions can be present in Parkinson's disease. And one more condition called malignant catatonia can be seen as a severe form of a psychiatric disorder where there is severe form of catatonia. It can mimic neuroleptic malignant syndrome, seizures, and everything. And a patient may have severe immobility, rigidity, mutism, posture, excessive opistotonic posturing, excessive motor activity, and the management of the malignant catatonia will be in lines with the neuroleptic malignant syndrome that we are going to discuss in the next few slides. And in malignant catatonia, electroconvulsive therapy may have some beneficial effect, and malignant catatonia is found to have high mortality rate. And regarding sometimes the complex partial seizures with status and myoclonic status epilepticus, all can present like some kind of psychiatric symptoms, and we have to evaluate those situations with EEG and MRI and other things, and we should not misinterpret as psychiatric syndromes, and proper evaluation for status complex partial seizures and status myoclonic epilepticus should be done. The next topic that we will be discussing is regarding the drug overdose, intoxication, and withdrawal states. So, psychiatric patients will be on multiple sedatives, antipsychotics, and other antidepressants and all those things. And once sometimes they are likely to take excessive amount of the medications knowingly or unknowingly, and it can lead to drug toxicity. So they can present with different toxin rooms, and the entire list will be very vast. But to go briefly, sedatives and hypnotics can cause CNS depression, and antipsychotics can cause hypotension, arrhythmias, and pseudo-Parkinsonian features. Serotonergic will be presenting with tremors, agitation, hyperthermia, diaphoresis, and clonus. And sympathomimetic medications will present with hypertension, tachycardia, agitation. Anticholinergics will be presenting with agitation, movement disorders, tachycardia, mydriasis, and opioid substances will be presenting with CNS depression, respiratory compromise, meiosis, bradycardia, and hyporeflexive seizures. So, and each management and antidotes will be a very vast topic, and we have to always remember that when a psychiatric patient comes to the ER or ICU with some optical with some symptoms matching into one of these toxin room, we have to always think in terms of drug overdose or toxicity. Next important thing that we see most commonly is the alcohol, and recently there has been increased incidence of cannabis intoxication and toxicity. Alcohol intoxication can happen within 1 hour to 24 hours of consumption of alcohol. The patient will be very drowsy, incoordinated, irritable, mood changes, and they can be in coma also. So when the patient comes with these symptoms, with the alcoholic smell in the breath and with the history of alcohol intake, we have to always think in terms of other differential diagnoses like head injury, hypoglycemia, post-ictal state, hepatic encephalopathy, meningitis, and all those things. And we should not directly jump into alcohol intoxication and miss the other differential diagnoses. Management will be symptomatic. We have to provide a protective environment. We have to avoid hypothermia. We have to correct hydration. And in cases of severe intoxication, hemodialysis may help. In case of cannabis intoxication, there may be delirium, panic attacks, myoclonic jerking, and psychosis. And even when a patient comes with cannabis intoxication and with such history, we have to always think of other differential diagnosis as we have done in the alcohol intoxication also, and the management will be the supportive care. And regarding alcohol withdrawal, there are different levels of alcohol withdrawal which appear at different stages after stopping the alcohol. The minor withdrawal will be seen in the first 24 to 36 hours, where there will be mild anxiety, headache, palpitation, and gastrointestinal upset. And we can see seizures also in the first 48 hours because of the alcohol withdrawal. And post 48 hours, we can see hallucinations and delirium tremens. Delirium tremens is the severe form of alcohol withdrawal, where there will be autonomic instability, delusions, agitated behavior, coarse tremors, and 50% of the patients with delirium tremens will be having seizures. These delirium tremens will be for the 4 to 5 days once it appears, and it may last for a few weeks also. The management of delirium tremens will be the main line of treatment is benzodiazepines. It may be lorazepam, diazepam, and in some countries or states where the lorazepam and diazepam are not available, fluordiazepoxide has also been advised. But when lorazepam and diazepam is available, they becomes the first line of therapy. And there are two things, two lines of treatment, that is front loading and symptom triggered. Front loading is we give a high doses of benzodiazepines in a very short duration of time. That is, with diazepam, we achieve light sedation with 5 mg. We repeat after 10 minutes. After 10 minutes, we give 10 mg. After 10 minutes, if patient is still not sedated and still irritable, we go for 20 mg. Then every 20 mg is given per hour till sedation, or CIWAR, that is Clinical Institute of Withdrawal Assessment of Alcohol Scale. A scale, we have to score it every hourly, and once that score is less than 8, we have to maintain that dose hourly. And other these less aggressive or thing is symptom triggered. We give diazepam 10 to 20 mg every 4th hourly and repeat 4th hourly till CIWAR score is less than 8. And the same kind of regimen is also available with lorazepam, and where 4 mg IV is to be repeated every 10 minutes till either of the aim of front loading is achieved. And the other important thing is lithium poisoning. It has very narrow therapeutic index, and it can present as acute poisoning and acute and chronic toxicity, or chronic toxicity with different symptoms. In acute and chronic toxicity, patient present with nausea, vomiting, just like acute GE, whereas in chronic poisoning, the patient presents with confusion, agitation, irritability, neuromuscular excitability, and all those things. So the management of lithium poisoning will be restore the sodium and water balance, because sodium should be monitored every 6th hourly, because lithium itself can induce nephrogenic diabetes insipidus, and sodium levels can alter very rapidly. So when patient presents early, whole bowel irrigation can be given, and if large amounts of lithium has been ingested based on the history, we can directly go for hemodialysis before the symptoms appear. And once the symptoms appear and the concentration of the lithium is more than 5 milliequivalents, we have to go for hemodialysis. Whereas in case of impaired kidney function or CKD patients, if concentration is more than 4 milliequivalents only, we have to go for hemodialysis. The next topic that we are going to discuss will be regarding the neuroleptic malignant syndrome and serotonin syndrome. These are the life-threatening conditions that we see in a patients who have been taking the psychiatric medications, and it can be caused by other medications also. And the neuroleptic malignant syndrome may be because of the adverse reaction to the dopaminergic antagonist or rapid withdrawal of dopaminergic medications. It usually presents within hours or days. It presents as a syndrome of altered mental state, fever, autonomic dysregulation, muscle rigidity, and there may be laboratory evidence of rhabdomyolysis with elevated CPK of more than 10 folds. It has a high mortality rate of around 5 to 20%, and the recovery usually takes a prolonged time of 1 to 2 weeks. The medications which are most commonly associated with the neuroleptic malignant syndromes are atypical psychotics and regular typical psychotics, most common being haloperidol, and all atypical antipsychotics like olanzapine, clozapine, risperidone can prescribe as neuroleptic malignant syndrome, and dopaminergics like amantadine can cause it, and other drugs like lithium can also cause neuroleptic malignant syndrome, and non-psychiatric medicines like metoclopramide can also reserpine, metoclopramide can also prescribe neuroleptic malignant syndrome. The management of neuroleptic malignant syndrome is by stopping all the dopamine blockers. When there is neuroleptic malignant syndrome has been precipitated by stopping the dopamine agonist, we have to slowly start in very low doses. And symptomatic management is very important because patients present in hyperparexia, temperature management or cooling of the patient with ice packs in the axilla, cooling blankets, and gastric lavage with ice water, and giving IV paracetamol is very helpful because patient is very agitated, irritable. Lorazepam should be given, and in severe cases, clonidine may be given, and clonidine also helps in stabilizing the autonomic instability in these patients. The specific measures that help in controlling the neuroleptic malignant syndrome being the bromocriptine in the doses of 2.5 mg twice or thrice a day. Other drugs being amantadine, levodopa, and dantrolene can be tried. And ECT has a controversial role in neuroleptic malignant syndrome. The other life-threatening complications that we see in patients on psychiatric medications being the serotonin syndrome, and it results from therapeutic drug overdose or intentional self-overdosing or inadvertent interaction between the drugs. Most common drugs that cause the serotonin syndrome is the selective serotonin reuptake inhibitors or SSRIs. The onset will be in less than 24 hours, and it can progress very rapidly. Resolution usually is expected within 24 hours if uncomplicated. The symptoms will be just like any other things like tachycardia, hypertension, tremors, myoclonus. Severe cases may present with very high temperatures of 104, 108, and it can cause autonomic dysfunction, delirium, muscle rigidity, rhabdomyolysis, and the severe complications may be myoglobinuria, seizures, severe metabolic acidosis, renal failure, and ARDS also. Medications that are mostly associated with serotonin syndrome may be tricyclic antidepressants, SSRIs, which are most common, and SNRIs, and mirtazapine, triptans, and stimulants like amphetamine. All these things can induce, but the most common being SSRIs. The management of serotonin syndrome is mostly supportive, and all serotonin medicines should be stopped first. The supportive care will be the required hydration, correction of the electrolyte imbalances, external cooling, and prescription. And benzodiazepines should be given to decrease the agitation and irritability. In severe cases of agitation and hyperthermia, cyproheptadine may be used. Initial dose being 12 mg with addition of 2 mg every second hourly if symptoms persist. Severe hypertension and tachycardia should be managed by beta blockers like esmolol, and nitroprusside can be used for management of severe hypertension. In severe cases, chlorpromazine intramuscular injection in a dose of 50 to 100 mg is used. It is advisable not to use bromocriptine and chlorpromazine if diagnosis is uncertain and neuroleptic malignant syndrome is a possibility. And the last topic that we will be seeing, and the most common cause of referral to the psychiatrist, should be a suicidal patient who comes to an ICU. The suicidal attempt is a self-injurious behavior with non-fatal outcome. Over 50 to 95% of the cases have history of psychiatric disorder or a prior treatment. The management of psychiatric suicidal patient with a psychiatric background will be in two parts. The first part will be management of the patient, and second part will be to prevent further suicidal attempts. So we have to always consider the things that increase the risk of suicide in the patients, like anxiety, aggression, intoxication, childhood abuse, and domestic partner violence, family history, and individuals' current living situation and social support. All the risk factors should be evaluated, and a trial should be made to mitigate all these risk factors. And if there is any previous psychiatric diagnosis, it should be entire diagnosis should be gone through, and it should be adequately treated. The safety measures that has to be followed in the ICU, that is very important, because the patient who has already attempted a suicide can always can do it the next time. So the patient should be kept in an area that can be easily observed. Lights, electrical fixation should be a concealed one, and one-to-one continuous observation of the patient should be done, and medication should be kept in the custody of ICU staff, and patient should not be in a capability to have the access of those medications, and the removal of all the sharp objects, dupatta, sari, and all those things should be away from the patient, and the patient should be always in the hospital clothes. A safety checklist should be shared with the staff of the patient care nurse and other staff of the ICU. The pharmacological interventions for patients of suicidal attempt will be antidepressants, anxiolytics, antipsychotics, and mood stabilizers. Lithium was also found to reduce the suicidal ideation in these patients. Electroconvulsive therapy was also effective in reducing the suicidality in acute situations, and other psychotherapeutic management like cognitive behavior therapy, dialectical behavior therapy, interpersonal psychotherapy in combination with other medical therapies has positive effect on managing suicidality. Thank you. With this, we have completed most of the psychiatric emergencies that we see in the ICUs. And next, Naveen.
Yeah, thank you, Siddharth, for that overview. I think you tried to cover all length and breadth of not just the substance abuse withdrawal, all the syndromes which we generally see as a psychiatric emergencies. First, we welcome Dr. Naveen, sir. It is a privilege and honor to have you on board, sir. Thank you for joining us.
Thank you, Ramana, sir. This is a wonderful opportunity to collaborate with the critical care team regarding the very worthwhile topic to discuss about the psychiatric emergencies in critical care. So and first of all, I will congratulate Dr. Siddarath. You have covered almost all the related topics in psychiatry emergencies. Yeah.
Sir, going to the interaction, which we want our all participant also to interact, we most commonly see that many of our patients knowingly, unknowingly will be having some or the other component of acute mental concerns. As Dr. Siddharth was pointing out, it can vary between 20% to 60% in a ventilated patient. So if that is the proportion of cases who are ill and sick and need some amount of psychosocial support, so do you think that a regular, this is a very diplomatic question, regular psychiatry consult should be done, and or a social counselor or a psychiatrist should be taking?
Yes, sir.
Please go ahead.
Yes, sir. I can echo this with the question also, because with the practical and as well as the publications also hinting that the psychiatrist consultations and utility in the ICU setups is underdiagnosed, underutilized. Because if you say it's the commonest referral condition like a delirium in ICU, there were almost all in medical ICUs, 65% of the consultant prevalence rates of the delirium was noted, but the psychiatrist getting the referral is around 1.7%. Means It's a roughly 60 times is lesser than the what they require. And another more concern also I can raise it for especially recent law amended condition, that's a suicidal attempt, which is now decriminalized by the as per the Mental Health Care Act also. So every suicidal attempt, when they having of medical attention, either it's a OPD, IPD, especially in an ICU setup. So the if the person is getting the evaluated the suicidal attempt and getting any psychiatric diagnosis, the follow-up rate will be the 53% when the people who are not getting any psychiatric diagnosis. Compared to the term, only 7% only they take the follow-up care. So in standardized care also, psychiatrist consultation, psychiatric diagnosis and evaluations, maybe they'd say improving the follow-up care and as well as the long-term treatments also. Yes, I can echo it, sir. Especially the Dr. Siddharth has revealed that many indications like delirium, alcohol withdrawal deliriums, very importantly, alcohol. So majorly, I can say some sort of confusion regarding the comorbid liver disease and having of withdrawal delirium, which is because of alcohol. The people are getting there is also some sort of skills are more required to disentangle the diagnosis also, because overlapping alcohol withdrawal syndrome, which is presenting in a delirium. So there should be the mostly alcoholic hepatic encephalopathy or it's a withdrawal delirium. So two are the completely different line of management. So that's why we need more academic discussions on these areas and the detailed history and psychiatric evaluation. And very importantly, the withdrawal management, what the loading regimen or symptom triggered regimen. Very importantly, we can cater this, especially comorbid liver disease and withdrawal deliriums. We have to very judiciously use benzodiazepines. And when and where required, overdosing of benzodiazepines also can be prevented with dexmedetomidine drugs also, injectable dexmedetomidine, alpha-2 agonist drugs, and various symptom trigger regimens, which we plan it. Because psychiatrists usually trained in this area, symptom trigger management and the utility of the psychiatric team in ICU setups will be the more beneficial also. Definitely I can echo. And yeah, please.
So we do come across this substance abuse very commonly in ICUs, but there will be always some kind of concealed information in the patient care areas which we see. So that is one more concerns what we actually realize. So do you face the same kind of thing? How do you actually differentiate between a ICU?
Yes, sir.
Psychosis to a delirium or ICU related delirium to a...
Yes. Maybe. Yes. Sorry.
Sir, you please continue. Dr. Kola is having some internet issue.
Okay. Can I continue? Yeah.
Yes, sir.
Yeah. So yes, sir. Wonderful question. That for the if some patients, especially alcohol withdrawal, some people will be intentionally hide some of the information because of, and some other patients are because of the nature of the emergency. That's withdrawal as well as delirium. They are altered sensorium state, so they are not supposed to reveal the alcohol history also. So in this scenario, we have to take a family members involving the background information to collect to alcohol history, and some of the biomarkers also we can able to utilize very judiciously in this area. The most sensitive biomarkers like GGT, CDT levels, and combination of the biomarkers, and very importantly, direct biomarkers. These are all the indirect biomarkers will be that gives the magnitude about the involvement of alcohol. Whereas the certain direct biomarkers like urinary ethyl glucuronides, sulfates. So these are the some of the direct biomarkers can give the picture about that yes, recent use of alcohol also. And second most thing is the maybe the insurance coverage sake also the people will be the nowadays we have seen frequently they are hiding the information. So we have to make the in a neutral environment and friendly environment history collection, background data, and surrounding other indirect alcoholic involvement. We can collect the history, parotid gland enlargements, any other comorbid alcohol-induced conditions. We have to physical examination and as well as mental state examination. We have to collect the data. Second thing is there the autonomic hyperarousal symptoms. Usually we see in the alcohol withdrawal delirium when compared to hepatic encephalopathy conditions. So any respiratory rate, pulse rate, and as well as Holter monitoring, there we can be able to check with the autonomic dysregulations are there. So these are all the highly markers. Second thing is the other associated alcohol withdrawal features also. So we have to collect the history. So these are all the even the person not in a position to giving the history of alcohol, we can able to find out some of the alcohol recent use also. These are the important we can able to again to direct the treatment also. And periodical observations also. Periodical observation very important because even though altered sensorium state also may be fluctuated and prominent tremors and as well as autonomic dysfunction features will be usually manifested obvious for the clinical team. So this close observation and nursing staff observations and physical examinations like a boozing smell and odors and more or less the family members involvement with the multiple people's are involvement. All this is getting the more accurate data. And not last but not
you are sweating profusely. I think it's too humid and hot there. You can wipe
very
up.
Very.
You can wipe up yourself.
Thank you, sir. Thank you.
So what we generally see, these are happening, sir. Not uncommon in these situations that we come across these unidentified or concealed information related to the substance abuse, and we come across them as a challenge. Other than that, we also see that the patients who are there in the ICU atmosphere, when actually one of our family member or one of us gets unfortunately into ICU, we do realize that the fear of disease, the fear of death, and the atmosphere of ICU, the discussion these are also keep a lot of psychosocial pressure onto the patient and his clinical condition. Affects, how do you actually that affect?
Yes, sir. So ICU environment, there sounds, lighting, and frequent turnover of the staff, and some sort of even the witnessing their colleague patients are getting maybe expired, and these are all the really they feel that as a threatened experience. Some people, and even that some of the people will be the having of vulnerable to get the even PTSD followed by the ICU stay. So that's why we have to psychiatric evaluation in that the person's risk and protective factors in that we can able to understand the how much the person resilient. And second most thing is that we have to prepare the patient if we have the chance. ICU environment will be this type of the things we are supposed to go into giving the care in this environment. And this environment provides you the best care of your medical support. And it will be the very important for the stage of the medical illness. The type of the education with the patient is having of conscious, we can able to discuss about the having informed consent manner. If not the person having in a position to hear, understand the implications about that stay, and there is ethical dilemma into providing the informed consent in this aspect. Even certain times restraints also we may require. So if whenever the person as short as possible, when the person is regain his consciousness, we have to collaborate that guy into the treatment and frequent co-attending of their friends and family members. So which make them to the less make them to the hostile environment and as well as more understandable about the procedures what is going on. So I think so when and where possible, frequent family members visit, and as well as friends, if they're possible, they have to involve into the treatment also. And this is the taking of risk and benefit because of critical care there where the mostly hygienic practices are required. So risk and benefit aspects we have to give the patient choice. Last but not least, as frequent the person getting the, we have to orient about what the treatment is going on, and the ICU setup, what type of environment will be provided. So person, if you agree, then the acceptance will be the more and more, and less anxiety and less phobic reactions.
So coming back to the management of this, sir. So we talk about ICU atmospheres are different. Noise decibels are different day and night. There will be active either monitoring noise. You see ventilator noise. You see
Yes, sir.
activities in and around. So there will be always a constant disturbance. If the patients do complain us about the sleeplessness or discomfort with that. So what is your take on that, sir? The noise levels and the disturbances.
Yes, sir. If it is mostly, we have to rely with the non-pharmacologically to make the patient to stabilize about the environment, because when and where, how much the possible to reorientation strategies along with the light and very low stimulating environment in the especially in night times, and so if possible, how much the possible to screen utilizing of the screens, and cut down of the noises as much as possible, and even the any night duty shifts and even shift is happening, introducing about the team to the patients also very important. My name is so and so, I am the next to the 8 hours of the time I have to supposed to giving that care for you, so any need, my job is the responsibility like this. If you briefing about the 1 minute of the time, what is about to yourself introduction, what is the role of our care, so the person will be feel that I am in the completely understandable environment and I am the safe in environment. And if especially in ICU time, how much the person getting more excitable, how much the less excitable, that much is that person feel that more understand, more accepted the environment. So that excitation we have to create it less possible. Thanks.
Other than that, day and night, if we
Yes,
have
sir.
a window with day and
Yes,
night
sir.
visibility, that
Yes,
also
sir.
keeping our patients in that. So what do you think?
Yes, sir. Best thing is, sir, day and night simulation. Not accurately, we can't able to make the patient to outside of the hospital environment. So within the ICU or in daytime, at least 60 feet distant eye light, eye vision supported environment will be he can able to see. Whether it's a simulated glassy environment also, it's a more appropriate in daytime, because of he will feel that some sort of the eye vision is getting relaxed. And second thing is the night time we have to light and the environment will be as less as possible. And every 6th hour or 8th hourly, the orientation about the time with the changing of lighting also according to that. So mid of the day, we have to give the brightest light as possible, and towards the end of the day, towards the night times, we have to less as possible. And when and where mild to moderate sleep disturbances, we can anticipate the guy, so we can give the melatonin supplementation even before sundowning, like a 5 p.m. or 6 p.m. at that time, rather than the giving the medications for that 10 p.m., 11 p.m. like that. So 6 and 7 p.m. if you provide it, maybe pharmacological interventions also can aid in the recovery.
So night and day cycling, this all melatonins and all came in a big way in the ICUs, more so for the night time. What is the role of melatonins in this?
Whether it's nowadays the orexin antagonist and as well as melatonin derivatives also, these two medications having of coming the picture in the market to stabilize the sleep and wake cycle rhythms. So yes, sir. Again, the people risk and benefit balance and concurrent polypharmacies, how much it's allowable for the medications. So in older age, we can able to limit the as much as possible polypharmacies also. And patients who are having of mild delirium only they have doesn't having of agitated symptoms, hypoactive delirium nature, sometimes subsyndromal delirium category patients. Some patients will be the subacute delirium, which is a prolonged more than 2 weeks of the time. There, the having of sleep rhythms are disturbed. So then, apart from the non-pharmacological methods, we can provide for the pharmacological interventions like whether it's a low dose melatonin supplementation as well as the orexin antagonist. If not possible, the low dose of lorazepam also, like other metabolic factors will be allowed for him.
Okay, now we are seeing more and more of the atypical antipsychotics in this management strategies. So, what is the change you have seen from a days of haloperidol to from a typical antipsychotics? Now we are looking for a atypical antipsychotics.
Yes, sir. This area we have to discuss with this because this is the very important topic. Atypical antipsychotics in the we previously in delirium patients and ICU agitation patients, we have to using for the injectable haloperidol or typical antipsychotics very commonly because the data is supported, long-term data and long-standing data, meta-analysis data is supporting for favor for that with a low dose. And but having of taking of certain precautions like a patient having of adequate hydration, QT interval supporting the QTC interval lesser than the 440 or 470 in the male patients milliseconds. And baseline after injection of the medication, baseline increasing of QTC not more than the 25% should be there. So then we have to take care about it. But after then, because of having of this QT prolongation, arrhythmias, and drug-to-drug interaction because of CYP3A4 enzymes. So the atypical antipsychotics coming in the picture, and having of risperidone of low dose will be the having of long-term data is supporting, and long-standing data is also supporting favor for that. And apart from the risperidone, agitated depression, a low dose of quetiapine and olanzapine will be secondary choices will be there. First and foremost choice is after haloperidol, risperidone is the most favored. Where the hypoactive delirium, apart from the again the risperidone is a good choice with having of good evidence, and along with that risperidone, there is some sort of the aripiprazole, low dose aripiprazole having of some favor when compared to olanzapine, ziprasidone, and clozapine. These drugs, because clozapine and ziprasidone, these two things are having of, especially clozapine, having of high sedation. So we have to reduce the doses, medications, avoid the medications where which having of more sedations.
So now coming back to the acute agitative state, we don't have injectables other than haloperidol alone. So what will be the alternative options? Do we see any possibility of injectable antipsychotics available in the future? Because we don't see any injectables other than haloperidol.
Yes, sir. Short-acting injectables is some of the drugs also there, sir, like chlorpromazine and as well as certain zoclopin Tixal. Maybe they have the chlorpromazine and they're not because of again the QT interval issues and drug-to-drug interaction issues, and so it's the limited their use. Only haloperidol has succeeded in providing this evidence. Apart from the haloperidol, risperidone, olanzapine, and aripiprazole, these three drugs are having of injectable drugs, but it is a having of long-acting injectable drugs, not it having of short-acting one. So maybe short-acting drugs will be available.
Injectable drugs are available in India?
Risperidone, olanzapine available, sir. Aripiprazole is still not yet available. Where the breviprazole is also coming in the market, and but it's also not available in the India.
So if we use risperidone in acute psychotic situation with an acute agitational state, will it be helpful? What are the indications for them?
Basically, it's a long-term treatment for the schizophrenia patients who is not cooperating for the oral medications, not for the acute ICU delirium condition. Because short-acting injectables only better choice.
Coming to Siddharth, you have actually gone through the whole chapter of ICU acquired all the alternations. So you said ICU CAM score, or you said RAS score and all. So how effectively it is translated in the bedside? Many had that doubt. So we may have different scores, but how frequently we actually at least look at these scores when the patient is some form of in altermentation?
So we have RAS score and CAM ICU score in our regular monitoring chart. Even the nurses need to chart it. What is the RAS score, or what is the level of sedation that is going on, or how active the patient is. The nurse and the doctor who is taking care of the patient has to interpret and write every day in the ICU. And
Please go ahead.
And most of the times when patient is already diagnosed to be having delirium, we do it on regular basis, but may not be done for all the patients who is not having, who is perfectly normal or whose sensorium is normal. It is not so commonly practiced, but once we think that the patient is having delirium or in altered state of sensorium, we regularly try to practice the RAS and CAM score.
Dr. Naveen, we have seen if a patient develops a ICU delirium, that itself actually increases the adverse outcomes of these patients in the ICU, first of all. And if it's not dealt well, that itself, if the delirium persists without appropriate care, the outcome again goes further adverse. So what is your take home to if the patient developed a delirium? First of all, developing itself, any ICU delirium itself is an adverse sign of a patient condition, but not managing it adequately or optimally will further lead into the adverse outcome. So, what's your take on that?
Yes, sir. Quick evaluation and assessment, comprehensive assessment of the patient is very much essential, especially in minding about that delirium, impending delirium near soon. In terms of the person risk factors like old age, polypharmacy, previous history of the delirium, and substance use intoxication withdrawals, and previous episodes of the withdrawal deliriums, and having of comorbid other medical conditions like a pancreatitis, liver disease. So these are all the markers for that, and especially intake CYA score, such as what the Siddarath has showed that Clinical Institute of Withdrawal Alcohol Revised score is there. If it is a more than 16, the score is there. At the time of intake, the person will be a chance of landing into the severe withdrawal and as well as delirium also. And based on the risk factors, so we have to keep in mind that person will be possibility for the impending delirium, whether it is a substance induced, whether it is other organic brain syndrome related deliriums also. If it is some sort of the non-modifiable risk factors like a older age, female gender, so these are the where are the non-modifiable risk factors at the context of the modifiable risk factors are there. We have to keep in mind. So delirium early presentation, especially like a people having of last couple of 1 and 2 days having of lesser than the 4 hours of the sleep, and mid of the night getting the more agitated at the time, and the person started to sub-syndromal hallucinatory experiences like a fluctuations, even sometimes the agitation, and suddenly out of the character the person is started showing anger outburst on the staff and as well as the family members. And these are all the markers for that the person is having of some sort of severe crisis going on. So these factors mainly.
Other than this, we also see you said ki mixed variant of delirium, hypoactive and hyperactive. Hyperactive delirium is a easy way to pick up whenever the patient is agitated and aggressive. We understand easy to. Hypoactive delirium is an area. What do you think? How frequently we encounter hypoactive delirium, and how many times it is misinterpreted like some other medical illness and has been ignored?
Yes, sir. Compared to hyperactive delirium, recognition of hypoactive delirium is a challenging one, and it's a commonly underdiagnosed. And that was one of the reasons for the prolonged hospitalization, severity of the presentation, and adversarial prognostic conditions. So these are all the will be possibilities. So recognition of the sleep-wake cycle rhythm disturbances, and the person started to experiencing of the even the agitation, mild, not what's called person's communication and orientation and fluctuation of the attention. These 3 parameters will be there. So we have to keep in mind that nursing staff observations, family members on how they are orienting about the peoples. So then they will be easy to pick up. And always other comorbid, other risk factors are there. So we have to keep in mind. And any major surgery like a hip replacement, cardiotomy, or cardiac-related interventions are there. So people usually the chance we can suspect about that maybe because of other factors will also there for the to explain about the delirium possibility there. So keep in mind, sir. So always the prolonged hospitalization, greater severity of the presentation than the expected, and multiple frequent calling for the care and utility. So these are all we can able to suspect there are some sort of psychiatric comorbidities going on. So whether it's a delirium, whether it's anxiety, whether it's a depression, then we have to clinical presentation why we can able to delineate, sir.
Okay, coming to the last part of it, sir, in a limited time. So we see this substance abuse very commonly, and initial few days after the admission, we don't see them to have any signs and symptoms. And we do see that happening after 3 days or 4 days or 5 days. So if we know a patient he was been addicted to some substance in the form of alcohol or nicotine or any other, prophylactically taking them into possibly these patients will land into delirium, what will be the way into manage it? Do we do any management of this patient prophylactic?
Yes, sir. Prophylactic management for the comorbid substance use, people always we have to take the history from the patients and history of the previous medical records, and so in the nutritional status by the observation itself.
If the family
Even
gives a history, if the family gives a history that the patient is consuming, and you know he has discontinued last 2 days and he has been hospitalized, that
okay,
also
sir.
is not uncommon.
Yes, sir. Then we have to record it last intake of alcohol. So we have to temporarily we have to associate within less than the 48 hours or 72 hours maximally. So withdrawals are there, but the seizures potentiality is there or not, we can able to the communicate by the standard rating scales. So that will be easy to we have to which patient is will be the having of we can keep watch more with high suspicion. Second thing is the previous history and past history and family history. So this is also important. Even the first time, the person having a withdrawal seizure in the previous time. So there is a kindling phenomena we can call in the brain. We can next time, so even the small severity of the withdrawal score also, the person within short period of time, he will be develop the withdrawal seizures. So this kindling phenomena can apply for the even delirium tremors also. So keep in mind that which type of high suspicion we have to give the intake of the CYR score, previous history, family history, comorbid history, polypharmacy of the drugs, non-modifiable risk factors like age, gender, and all this we have to keep in mind.
I think, sir, we had a good discussion. We have a few questions also which we'll take.
Great.
So there were questions related to maximum dose of haloperidol in 24 hours.
Depend upon the severity, sir, and indication about the patient and the patient having of the biological and physical makeup of the fitness of the guy. So there is a clinical experience. We can go up to the even 500 mg also, sir. Even the 5 mg of haloperidol, some patient may they require and they can able to tolerate even 500 mg the regards. But clinically, I can say 120 mg that we have to see in the maximum, sir. But up to so far,
injectables, what we do in a regular practice in ICUs vary between 5 mg to start with, and maybe can be repeated up to 20 mg in ICU. That's what is commonly injectable. I mean to say parenteral dose which we use. You are talking about oral dose, sir?
Yes, sir. Even 120 mg of injectable for the manic patient in psychiatric ICU, we can inject this. Because psychiatric ICU, especially in mania, acute psychotic agitation, sometimes we have to use a chemical restraint. So for the chemical restraint, this haloperidol is a very good drug in injectable ones.
There is some interesting question related to what are the marker of alcohol use? How do somebody may say we are not alcoholic, but you are typically seeing alcohol withdrawal? How do you actually?
Yes, sir. So commonest high sensitivity biomarker with the combined GGT, CDT, we can able to apply, sir. And if it's available in our laboratory, a direct biomarker like a UDT, say urine, ethyl sulfate, as well as the ethyl glucuronide drugs. So we can this molecule we can test it.
So they are available in regular labs, sir, or you have to send somewhere?
Ethyl glucuronides and ethyl sulfate we can use for the specialized laboratories. This requires specialized biomarkers availability. But GGT and CGT is available, I think so, commonly in the majority of labs. Combined biomarkers will be having of great utility rather than the isolated biomarkers.
Siddharth, any specific points you wanted to make?
I want to ask Naveen, sir, regarding the drugs, many doctors or physicians will be prescribing for alcohol withdrawal fluorodiazepam. When I have gone through the literature, the role of fluorodiazepam has been mentioned only in the states or countries where fluorazepam is not available. There is a separate flow chart. And also in the guidelines when I have gone through, they are also advising not to start antipsychotics like haloperidol directly, because there are some
True.
So haloperidol has to be started only when there is coexisting some psychiatric disorder, or otherwise we should not start haloperidol as a first line. And I have not seen any guidelines regarding olanzapine or quetiapine in this alcohol withdrawal, which many of the doctors, physicians will be prescribing as a first day for the alcohol withdrawal patient. So can you give some clarity regarding that one, sir?
Good, Siddhartha. Absolutely, alcohol withdrawal antipsychotics role is absolutely not good evidence. Only benzodiazepines, and that too long-acting benzodiazepines, will be having a good favorable profile. In that, chlordiazepam as per the NICE guidelines, which is the UK guidelines, giving the higher priority, whereas the USA and as well as Australian guidelines prioritizing for the diazepam more. But it's a both are the long-acting one. Nothing big mistake for the if you selected chlordiazepam or diazepam. Even if it is a because of metabolic profile is not allowing for the long-acting benzos, then the lorazepam, oxazepam will be the more favorable. Oxazepam more given by the UK guidelines, whereas the USA and Australia guidelines favoring for the more lorazepam. So depend upon the renal and as well as metabolic profiles, they allow that. Second thing is the prescribing of antipsychotics at the first day of the withdrawal syndrome. I think so, and the haloperidol in olanzapine, whatever the two drugs, it absolutely doesn't have enough role in preventing withdrawal symptoms. Even more than that, this will be the added more morbidity for the patient and more chance of the QT interval prolongations because of acute withdrawal times, and the patient already having of atomic arousal features are there. So tachycardia is there. So more chance of arrhythmias will be there. So only the person agitation is caused by because of the some perceptual disturbances like hallucinations predominantly, and not responding for the traditional benzodiazepines. Then we can give the low dose of antipsychotics like a 0.125 mg of haloperidol, 0.25 mg of haloperidol, and with that, even that we can able to monitor with the ECG for the QT prolongation.
And also the dose of lorazepam or diazepam we give for alcohol withdrawal is very less. We give 1 tablets at 4 mg lorazepam. But what is being advised is to repeat the dose every 10 minutes till the patient calms down.
Yes, doctor. I can give here a clarity about that. There is something called loading dose, which is there for the acutely we have to make the patient to stabilize in ICU setup. If where the anesthesia help is available and mechanical ventilations are, we can able to give at any immediate point of the time. So if it is the type of support we have, then psychiatrists usually give the higher dose also. We are using for the lorazepam up to even 60 mg of lorazepam parenterally. So you can understand. Generally, we say it's a textbook saying that if it is a 16 to 18 mg of lorazepam is increasing, maybe we are going for the higher benzodiazepine we are using. And so there is a risk will be there. So loading dose is providing for us to within short stabilization. Within 1 day, we can stabilize the patient. Whereas the symptom trigger, we have to, as per the based on the SIVA-AR score, we can give the when up to repeated assessment. For example, SIVA-AR score lesser than the 10 is their score. then we have to give for the 6 to 12 hours of the repeated assessments required. Then the repeated assessment, repeated doses are required. Whereas the CYA score is the more than 16, then we have to assess for the every 1 to 2 hours. So whatever the dose per a day we calculated for benzodiazepine, that is the total dose of the benzodiazepine, we can utilize that, we can able to replace with the oral form when the patient getting the stabilized consciousness.
Okay, I think in the interest of time, we had an interesting and nice discussion. We thank Dr. Naveen Kumar and Dr. Siddharth in bringing this topic and enlightening all of us. Thank you all the participants, and we thank all of you for being here. And I conclude the session. Thank you.
Thank you, Raman sir.
Thank you.
Thank you, Siddharth.
Thank you.